welcome to Unacademy. Let's crack it. I am Dr. Shilpa Dinesh. I'm a practicing pediatric consultant educator in Unacademy. I have an experience of teaching undergraduate and postgraduate medical students, and I have done my MBBS and MD from Rajiv Gandhi University, Health Science. So today we are going to have another session of random pediatric quiz. So I have included topics like immunization. I've included respiratory system, which is specific to pediatrics today. Okay, so before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform, and there are a lot of benefits you can avail from this platform. Firstly, the daily live classes. So there are various educators in this platform, and they have regular classes. You can attend your favorite educator's class, engage in discussions, ask your doubts, and all your doubts will be immediately answered in the live chat box. Next, coming to the structured course. So whenever you're preparing for your entrance exam, you need to have a structured approach. You need to plan really well. So by the time you give your entrance exam, you would have revised very well. So here in Unacademy, all our courses are structured in line with your exam syllabus, and that is going to be a huge boost for your preparation. Next, coming to the live tests and quizzes. So whenever you're preparing for your entrance exam, you need to evaluate yourself. You need to know what are your strong areas, what are your weak areas. Only then you will be able to concentrate on the topics which you are not that strong at. So that is only possible if you attend as many tests and quizzes as possible. So here in Unacademy, there are regular tests and quizzes happening, and this will help you to evaluate yourself better. It will help you to analyze. Okay? So next, coming to the unlimited access. So once you subscribe to the subscription, you get unlimited access to all the classes that is exclusive to the subscription platform. Even if you've missed the live class, you can go back and watch the recorded classes again and again, all this in the comfort of your home, in the comfort of your own device. So I highly recommend this platform, and using this platform from the beginning part of your preparation will go a long way. Next, coming to the top educators. So these are the top educators in the platform, and they have regular classes happening in their classes as well. Coming to the courses offered, all the 19 subjects required for your NEET PG preparation are taught in this platform. And if you go to the Unacademy app, you can see that there are various courses like the foundation course, the batch course, the crash course. So these are all compact courses of various subjects. So based on your requirement, you can attend these classes. Next, coming to the NEET PG subscription package. So as you can see, the NEET PG subscription package varies from 1 month to 2 years. I would highly suggest the 1 year or the 2 year subscription as it is very reasonable and economical. And especially for the students who are in their 3rd year and their final year, who are in the internship, who do not have that much time to attend all the classes, attend all the live classes, they can actually take this 1 year or the 2 year subscription. For the students who are giving their NEET 2020, the 6 months subscription should be good enough. The 6 month subscription costs you 20,000, and using my code Shilpa 10, you get a 10% discount, and it will come up 18,000. While the 1 year subscription costs you 25,000, and using my code Shilpa 10, you get a 10% discount, it will come up to 22,500. Okay, the 2 year subscription costs 30,000, and using my code Shilpa 10, you get a 10% discount, 27. So as you can see, the rates are very reasonable, very economical. I would highly suggest this Unacademy subscription. You're only a click away from your subscription. You can just you can download the app, and then you can go for the subscription package, whichever you prefer. Okay, so now coming to today's topic. Okay, the first question being, let me see if anyone of you are there. Okay, fine. So I'll start with today's first question. Kinky hair disease is a disorder where an affected child has a peculiar white stubby hair. White stubby hair. There is brain degeneration which is seen, and the child dies by the age of 2 years. Now, Mrs. X is hesitant about having children because her 2 sisters had sons who died with kinky hair disease. Okay, her mother's brother also died of the same condition. Which of the following is the possible mode of inheritance in her family? Which is the inheritance? Yes, very good, Sumitra. So the answer is X-linked recessive. So what do you see over here? There are two boys. Okay, there are two boys who are dead. Okay, okay, they who are dead. So there is two women. Wait 1 second. Two boys. Okay, who are dead. So there are two sisters, right? So there are two sisters. One of the sister has these two kids who are dead. So another um, the mother, the grandmother had two daughters. They were not affected, but the mother's brother was affected. Okay, so there would have been a gene. The mother would have been a carrier, which the mother would have transmitted to her daughters, and from there the sons would have got the disease, and they had succumbed. So the answer is X-linked recessive. Okay, so very right, Sumitra. The answer is X-linked recessive. Next question. Analyze the following pedigree and give the mode of inheritance. Okay, analyze the following pedigree and give the mode of inheritance. Is it autosomal dominant? Is it autosomal recessive? Is it mitochondrial inheritance, or is it X-linked dominant? Or is it X-linked dominant? So see the pedigree. Aram se take a complete look at the pedigree and tell me what is the mode of inheritance. Yes, so very good, Sumitra. So the answer is X-linked dominant. So as you can see, the male is affected here. So the father has X and Y. So if you can see only the girls are affected over here. So the X is the only X is passed on to the girls, right? So if since it's an X-linked dominant, having even a single abnormal X will present the disease. So over here next, the affected girl has transmitted the disease. It could be to the male or the females. Anyone could get affected. But if the father is affected, that will surely cause 100% transmission to the males. Yeah, so the father. So male to female transmission. Okay, so the sons do not get affected over here. If the father is affected, then the girls will surely get affected. But yes, if the mother is affected, then the mother can transmit the disease to either the boys or the girls. But if the father is affected, then only the daughters get affected. So this is X-linked dominance. So very good, Sumitra. We'll go to the next question. Which of the following is increased in Prader-Willi syndrome? So which of the following is increased in Prader-Willi syndrome? Is it growth hormone? Is it luteinizing hormone? Is it follicle stimulating hormone? Or is it ghrelin? So tell me, what is increased in Willi? Yes, very good. So the answer is ghrelin. Ghrelin. To tell me, Sumitra, which is the chromosome which is affected in Prader-Willi syndrome? Which is the chromosome which is affected? And what kind of genetic defect is this? Why it is ghrelin. So over here, these children will be obese. There will be hyperphagia in these children, right? So there is hyperphagia. Now tell me, what is the chromosome which is affected? And what kind of what is it? Genetic defect is this? Yes. So chromosome 15 is involved. What kind of genetic abnormality is there? that is called as genetic imprinting. There is unipaternal disomy. So there is this absence or loss of function of the gene which is inherited from the father. So either you should get both copies of the father and the mother in the chromosome. Okay. Most common cardiac lesion in Down syndrome. Most common cardiac lesion in Down syndrome. Yes. So the answer is atrioventricular septal defect. So the most common cardiac lesion in Down syndrome is atrioventricular septal defect. So remember, this is the or it is also called as the endocardial cushion defect. So this is the most important cardiac lesion in Down syndrome, endocardial cushion defect. Keep this in mind. So it is either the atrioventricular septal defect. We are talking about not just the atria or the ventricle. So the atrioventricular septal defect or the endocardial cushion defect. So this is the most common cardiac lesion in Down syndrome. Okay, next. Most common cardiac defect in Turner syndrome. Is it VST? Is it pulmonary stenosis? Is it bicuspid aortic valve, or is it endocardial cushion? The most common cardiac defect in Turner syndrome. Is it VST? Is it pulmonary stenosis? Or is it bicuspid aortic valve? Or is it endocardial cushion defect? Very good. So the answer is bicuspid aortic valve. So I have been telling you all in Turner syndrome, it is most commonly the aorta which is affected. Aorta which is affected. Okay. So there is something called as the Noonan syndrome where you will see the pulmonary stenosis. So in conditions where they show there is a wet neck and there is pulmonary stenosis, then it is most probably a Noonan syndrome. Okay, so other cardiac defects which can you hear me, Sumitra? I'm talking a little softly because I've got a little throat pain. Are you able to hear me, Sumitra? Just let me know. Just let me know if you want me to talk a little loud. Okay, so I'm a little softer today because I've got a little pain in the throat, so I may not able to talk very loudly. Okay, so the other defects are the coarctation of aorta. Coarctation of aorta is also common in Turner syndrome. So the one is the bicuspid aortic valve, the other is the coarctation of aorta. While the pulmonary stenosis or the involving the pulmonary artery is more in the Noonan syndrome. Noonan syndrome we have discussed is an autosomal dominant um, disorder. Next, a 1-year-old child with severe dehydration would be expected to present with irritability, poorly drinks water, absent urine output, or hyperthermia. So a 1-year-old child has severe dehydration. What would you expect this child to be? So irritability, poorly drinking water, or is there absent urine output, or is there hyperthermia? So how is it? So we're talking about severe dehydration here. So read the question properly and then answer. We're talking about severe dehydration. Yes, Sumitra, right? The answer is absent urine output. So since there is a severe dehydration, chance of a child having a diminished or an absent urine output is high. So we'll have a quick look at the classification of dehydration. So very important is these three. So you see the condition of the child. Okay. So to tell there is some or a mild or there is moderate or severe dehydration about various category. So condition of the child. So if the condition of the child is well, she's alert. If the child is alert, or if the child is restless or irritable, we'll take it as okay, mild, moderate, and severe. Okay, in moderate, the child will be very irritable or very restless. In severe, the child will be lethargic and unconscious. So based on the mental status of the child, we are able to divide the dehydration. Next, coming to eyes. Okay, so the eyes is normal. Okay, but very important thing when you see the eyes, is you have to ask the mother or the parent the child's eyes normally sunken, because that will give you a clue, because some children have a normally sunken eyes. So you might actually confuse for a normal child to have a sunken eye. So always ask the mother or the father, is the eyes of the child normally sunken? That will give you a baseline idea about how is the eyes of the child. So one is normal, mild. If it is moderate dehydration, there could be a sunken eyes, and severe dehydration, very sunken and dry eyes. Tears are present in mild dehydration, while in moderate dehydration, the tear film is absent, and even in severe dehydration, the tear film will be absent. Next, coming to the mouth and tongue. Okay, the mouth is moist. Okay, dry in moist in mild, while in moderate dehydration it is dry, and in severe dehydration it is very dry. So when you see the tongue, coming to the thirst, this is very important. This thirst part is very important. So in most clinical scenarios, they use the thirst to give a clinical picture. Okay, so in mild cases, the child is drinking normally and the child is not thirsty. Okay, but in a moderate dehydration, you can see that the child is very thirsty, is wanting to drink water very eagerly. The child drinks water eagerly. This is very important. Okay, next, coming to severe, the child drinks poorly or doesn't have the strength to even drink the water. Okay, so not able to drink water. So this is a very important point which will help you differentiate between a moderate and a severe dehydration. So remember this. Next, coming, so basically the best part to elicit the skin pinch or the skin turgor is the abdomen. So when you pinch the skin, okay, the skin goes back immediately, is mild. When it goes slowly, that is less than 2 seconds. It takes 2 seconds. Okay, it takes at least 2 seconds. Okay, 2 seconds, then it is slow. But if it takes more than 2 seconds, then it is very slow, and that is a feature of severe. So remember, the skin turgor or the skin pinch, the best area to elicit is the abdominal skin. Next, coming to decision. So based on the signs, so if the child is well alert, if the eyes are normal, tears are present, mouth and tongue is moist, and the child is drinking normally, then there is no signs of dehydration. Okay, now coming to the moderate criteria. So if there are two or more signs present, okay, in the criteria, then it is some dehydration. Okay, in severe, if there are two or more signs of severe criteria, then it becomes severe dehydration. And based on that, we have categorized the treatment as plan A, that is for mild dehydration, and plan B for moderate dehydration, and plan C for severe dehydration. So I have done a class on diarrheal disorder, so where I have discussed about the management of loose stools and diarrhea. So there I have clearly told you about how is plan A, plan B, and plan C. Okay, so you can go and have a check on that class. So remember, so now, so when, and another very important thing is the urine output. So that is not given in the class, in the classification. So in urine output is very important. So as the dehydration becomes severe, the urine output is highly diminished or absent or absent. So this you have to remember. Okay, so urine output. So always when a child comes with loose stools or diarrhea, we have to ask a question: how is the urine output? If the child's urine output is normal as before, then we can still, advise the child, advise the parents, and send them home and tell them to follow the home therapies, home treatment. But if the urine output is decreasing, then the child might have to be admitted and given fluids, or ORS monitoring should be done. Next, signs and symptoms of meningitis in the infant include all of the following except lethargic, seizures, high-grade fever, or sunken fontanelle. So signs and symptoms of meningitis infant includes all of the following except. So we're talking about meningitis in an infant. What are the signs and symptoms? Okay, so one of the following is not a sign and symptom. Yes, very good, Sumitra. So the answer is sunken fontanelle. So what should be the fontanelle be in meningitis? What should be the fontanelle be in meningitis? So the fontanelle is bulging, right? So in meningitis, the fontanelle is bulging. Okay, so that goes out of the that out of question. So the sunken fontanelle is a feature of dehydration, while a bulging fontanelle is a feature of meningitis, as we since there is a raised intracranial pressure. Fine. Next question. Following are included in the criteria for SIRS, that is systemic inflammatory response syndrome, except, so what is not included? So is it tachypnea, bradypnea, tachycardia, or bradycardia? Following are the criteria which are included for SIRS, that is severe inflammatory response syndrome, except severe inflammatory response syndrome. Tell me what is not included. Tachypnea, bradypnea, tachycardia, or bradycardia? No. The answer is, so I'll give you another few seconds for the others to answer. So the answer is bradypnea. Okay, bradypnea is not there. Tachypnea, tachycardia, bradycardia, all are there. So I will tell you what is the definition. So now there are four criteria. Okay, there are four criteria. At least should be there to tell it is cyst. Out of the two, one should be either abnormal temperature or abnormal leukocyte count. Okay, abnormal temperature. Okay, a high temperature or a low temperature. So hyper or hypothermia. Okay, hyper or hypothermia. So an abnormal temperature is one. Second is tachycardia. Okay, so tachycardia. So or bradycardia. Third is respiratory rate more than 2 standard deviations above the normal age. So there is tachypnea, and a leukocyte count, either an elevated leukocyte count or a decreased leukocyte count for the age. So remember, there are four criteria. So one is the temperature, another is the heart rate, respiratory rate, and the leukocyte count. So both temperature, heart rate, and leukocyte count, either if it is increased or decreased, comes under CIS definition, while the respiratory rate is only increased, so only tachypnea included in the CIS, while bradypnea is not included. Okay, so remember that. So out of the four criteria, one should be either an abnormal temperature or it should be an abnormal. Okay, so this is about systemic inflammatory response syndrome. So this is a very important topic you have to keep. Next. Yeah. A child is brought to the casualty with the history of fall. Child opens his eyes when called his name, very irritable. Okay, he's very irritable. He withdraws his arms when given a painful stimulus. What is the GCS in this child? This is a very important topic. It is asked in various other subjects as well. So the GCS. So in the GCS of a child is little different. That is why the question here. So is it E, the eyes 3, verbal 4 or motor 5? Or is it eyes 3, verbal 3 or motor 5? Or eyes 4, verbal 4 or motor 3? Or eyes 3, verbal 3 or motor 4? So tell me what is the GCS score? Tell me. Eyes, eyes, verbal and the motor. Think properly, see properly. You should be knowing every component for the eyes, for the verbal and for the motor part. How many components are there? That will give you a clue. So how many points are there for eyes? How many points are there for the verbal commands? Or how many points are there for the motor? Okay. So now Prajay has answered right. So the answer is eyes 3, verbal 3 and motor 4. So we'll have a discussion now. So basically now remember eyes has a score of 4. Okay. Verbal response has a score of 5 and motor response has a score of 16. So it total comes up to 15, right? So now this child was opening his eyes when called his name. So his score for eyes becomes 3. So he was responding to voice. So right. So for voice it becomes 3. So I becomes 3. While verbal response. So in an older child you see oriented, confused, inappropriate words, incomprehensible words, none. But while an infant and child, you have to know that the child is smiling, he's happy, fixes and follows the object, that is fine. While a consolable cry, so the child is crying, but you're able to console the child, that becomes 4. But a child who is irritable, persistently crying, cannot console, that becomes 3. So over here, this is very important. If the child is consolable or not. So if the child is consolable is 4, not consolable is 3. Restless and agitated is 2, and there is no response is 1. So over here, the child is irritable, right? Irritable, so it becomes verbally 3. Coming to the motor response. So if the child is able to obey the commands, is 6. Okay. Localizes pain is 5, withdrawals is 4, flexion is 3, extension is 2, and none is 1. So the child was able to withdraw the hand. So when you give a painful stimulus, this child was withdrawing the hand. So that is why motor becomes 4. Okay, so in here we were talking about eyes 3, verbal 3, and motor 4. So this is a very important chart. Glasgow coma scale is very important. Okay, so this comes for medicine, this comes for surgery, okay, for pediatrics. So this is a very important slide. Keep in mind this will come in your exams. Okay, and this there is a chance for you all to get confused, so read this well. So remember, in eyes there are 4 components, in verbal response it's 5, and motor it is 6. That will help you to remember better. So now if you suddenly come to a question and you don't have a clue how many components are there in each, you will forget. Okay, so remember that. Next question. Okay, what is D in the ABCDE approach of managing a sick child? Okay, in the ABCDE, what does D mean? Is it disability, disorder, disease, or deprivation? Tell me, is it disability, disorder, disease, or deprivation? So in the ABCDE approach of managing a child, what is it? What is D of ABCDE? So there is a, before it was only an ABC approach. Now there is ABCDE. So what does mean? One child who comes to the casualty, a child who is sick. So we have to see the ABC. The first comes A, then comes B. Yes, yes, Prashai. So the answer is disability. Okay, so basically this child can have a neurological disability. So it is disability. Okay, so what is A? A is airway. Okay, so basically you have to see if the airway is blocked or is it clear or is maintainable. B is breathing. So how is the respiration of the child? Okay, breathing. C for circulation. Check for the color of the child, pulse of the child, blood pressure of the child, circulation. Disability, seeing the neurological status. You see the Glasgow coma scale. Okay, that becomes very important. Okay, so disability. Last E is the exposure. What is exposure? So basically when a child comes, completely expose the child and check for if there is any bite or is it any trauma or is it any bleed. So that, so, and completely expose the child, or if the child has any toxin exposure happening, so remove all the clothes and child in an open space, see that there is no crowding. So this is the ABCDE approach of managing a child who is sick and who comes to the casual who is sick. Fine. Next, when do we term, okay, when is it termed as fluid refractory shock? Okay, so is it after 3 saline boluses of 10 ml per kg, or is it after 3 saline bolus of 20 ml per kg, or is it after 2 saline boluses of 10 ml per kg, or after 2 saline boluses of 20 ml per kg? So when do we term in the resuscitation as a fluid refractory shock? So tell me, when is it a fluid refractory shock? Yes, Sumitra, right. So after a 3 saline bolus of 20 ml per kg, we give a total of 60 ml per kg at interval. So we suddenly don't give 60 ml per kg. Give at 20. So the thing is, suddenly give fluids can cause fluid overload. Okay. So always it is given in the interval of 20 ml per kg. Okay. So you do give 20 ml per kg, assess the child. So see the pulse, blood pressure. Okay, so basically pulse is very important. When a child's pulse is feeble, we give fluid boluses. So you give 20 ml per kg. No improvement, another 20 ml per kg. No improvement, 20 ml. At this point, if there is no improvement, it's called as the fluid refractory shock. Okay, at this stage it is called as the fluid. So in this stage, you start the child on inotropes. Okay, so the dopamine, dobutamine, adrenaline, noradrenaline, based on the type of shock, the inotropes are added. Fine. Next question. Warm shock is a feature of which type of shock? Is it hypovolemic shock, cardiogenic shock, distributive shock, or septic shock? Warm shock is a feature of which type of shock? Is it hypovolemic shock, cardiogenic shock, distributive shock, or septic shock? Think and answer, don't be in a hurry. Think about each and every cause. How is a hypovolemic shock present? How does a cardiogenic shock? What are the causes for hypovolemic? So yes, very good. So the answer is septic shock. Okay. So these patients will have all. So main thing, what you know, when a child who comes with shock, pulses are feeble, peripheries are cold. But in septic shock, the thing is there is a high temperature and the pulse and the are warm. Okay, so this is a specific example for warm shock. So septic shock presents as warm shock. Okay, fine. Next, coming to the next question based on the immunizations, toxic shock syndrome can occur due to hepatitis B vaccine, measles vaccine, or BCG vaccine. So we're talking about toxic shock syndrome. So this has been a regular repeat. So tell me, toxic shock syndrome occurs in which of this following vaccine? Is it hepatitis B, measles, DPT, or BCG? Which vaccine leads to toxic shock syndrome? And this has been one of my favorite questions as well. So very good, Sumitra. So the answer is measles vaccine. So this leads to a common cause of toxic shock syndrome. Fine. Next question. Tell me what is the vaccine associated paralytic poliomyelitis associated with which type of OPV strain? Is it OPV strain 1, 2, 3, or all of the above? So vaccine associated paralytic poliomyelitis happens because of which OPV strain? Is it OPV strain 1, OPV strain 2, 3, or all of the above? Very good, Prajay and Rehan. So the answer is 2. So 2, so OPV strain 2, okay, is associated with vaccine-associated paralytic poliomyelitis. So now tell me, in before it was a trivalent OPV, right? Trivalent OPV. All the three strains were there. Now it is a bivalent OPV. So in the bivalent OPV, what are the OPV strains which are there? In the bivalent OPV, which are the strains which are there? I know you know the answer, but I just want you to tell me now so that we will remember better. So before now we have, you all know that the trivalent OPV has been replaced by a bivalent OPV. Now no more. Yes, very good, Sumitra. So though in the bivalent OPV it is 1 and 3 strain. The two, the OPV, the OPV strain 2 is not being used anymore. So now the trivalent OPV is being replaced by the bivalent OPV, and the strain 2 is not there in the bivalent OPV. It is the strain 1 and 3 now. So keep that in mind. Okay. So when it comes to vaccine associated paralytic poliomyelitis, it is the strain 2 which causes the vaccine associated poliomyelitis. Fine. Okay. Seizures are most likely due to which component of DP? Seizures are more likely due to which component of the DPT? Is it diphtheria, pertussis, tetanus, or all of the above? Yes, very good. So the answer is pertussis. So based on, so why now? What kind of a pertussis vaccine is being started? I mean, to prevent this seizure. So in this DPT now there is this ACL. So basically, this pertussis is caused by the whole cell pertussis. So now, before what we used to give in DPT, this pertussis was a whole cell pertussis. Now there is the acellular pertussis, okay, which is we give the whole cell and acellular, but in all the foreign countries they're using acellular pertussis. In India it's still the whole cell pertussis which is being given in the government setup, but in the private setup there is an option for the patients to go for the acellular as well. But tell me what the acellular pertussis, if it is a, okay, if the DPT includes the acellular pertussis, so this acellular is which kind of a vaccine? Tell me what type of a vaccine is it? What kind of a vaccine is it? Like, killed or live attenuated. What kind of a vaccine is it? Pertussis, no, the normal whole cell is, no, you know it. What is the acellular type pertussis? What kind of a vaccine is that? What is it? So it is a recombinant vaccine. Okay? It is a recombinant. Okay? So here this is a toxoid. Pertussis toxoid. Next. Which of the following is a conjugated vaccine? So tell me out of the following, which is the conjugated vaccine? Is it hepatitis B, rubella, H influenza, or pertussis? Which is a conjugate vaccine? Which is the conjugate vaccine here? Yes, very good. It is Haemophilus influenza. Haemophilus influenza is the conjugate vaccine. Okay, so tell me what is the hepatitis B vaccine? So tell me what is the hepatitis, which type of vaccine is hepatitis B? What type of vaccine is hepatitis B? Yes, very good, Sumitra. Hepatitis B is a recombinant vaccine. We're talking about varicella. So tell me, varicella is a killed, recombinant, inactivated, or a live vaccine? What kind of vaccine is a varicella vaccine? What kind of vaccine is a varicella vaccine? Is it a killed, recombinant, inactivated, or a live vaccine? Yes, very good. So it is a live vaccine. Varicella is a live vaccine. Okay, tell me some examples for killed vaccine. Tell me some examples for killed vaccine. Tell me some examples for killed vaccine. Yes, yes, IPV. Then all the toxoids, right? Yeah, toxoids, right? Next, what other vaccines come? The whole cell pertussis. Okay, that is also killed or inactivated vaccine. So killed and inactivated come under same. So next come tell me the recombinant vaccine. So what are the recombinant vaccines? So recombinant HPV vaccine is a recombinant vaccine. Ascilla pertussis, if it is used, the recombinant vaccine. Hepatitis B is a recombinant vaccine. Okay, live vaccines, most of the oral vaccines. So now oral we have two. One is the OPV and the rotaviral vaccine. Most of the oral vaccines are live vaccines. Okay, next other live vaccines or most of the viral vaccines are the live vaccines. Okay, so remember hepatitis A, varicella, MMR, the measles, mumps, rubella. Okay, now tell me what is BCG vaccine? What is BCG? BCG is which kind of a vaccine? Killed, recombinant, inactivated, or live? What is a BCG? BCG is a live vaccine. Okay, so these are the vaccines and the various categories you have to know. Fine. Next, what is the stabilizing agent in OPV? Is it magnesium chloride, aluminium chloride, sodium chloride, or potassium chloride? What is the stabilizing agent in OPV? Tell me what is the stabilizing agent in OPV? What is the stabilizing agent in OPV? It has been a previous question. Okay, tell me. So Prajay is right. The answer is magnesium chloride. Okay, do not get confused. So most of the other vaccines there is aluminum chloride which is used, but for OPV it is the magnesium chloride. So magnesium chloride is a stabilizing agent in OPV. Remember magnesium chloride. Okay, for OPV it is magnesium chloride. Magnesium sulfate is being used in measles, but magnesium chloride is for OPV. Fine. Next question. DPT is contraindicated in. family history of convulsions, progressive neurological disease, cerebral palsy, febrile convulsions. So DPT contraindicated in which condition? For family history of convulsions, or if there is a progressive neurological disease, cerebral palsy, or a febrile convulsions. Where is DPT contraindicated? Yes, very good. So it is contraindicated in a progressive neurological. See, cerebral palsy is a static neurologic. Okay, so over here, out of the following, you should know that progressive neurological disease is a contraindication for DPT. Fine, very good, all of you. Now tell me, which is the strain which is used for measles vaccine? Which out of the following is a strain which is used for measles vaccine? Is it Oka strain? Is it Edmundston Zagreb strain? Is it Gerald Lynn strain? Or is it Danish 1331 strain? So tell me, first you'll tell me the answer and then tell me what are these strains are used in which vaccine. So now tell me, in measles, which is the strain which is used? Yes, very good. So the answer is Edmundston Zagreb strain. Everyone knows this. Measles vaccine, it is the Edmundston Zagreb strain. So now tell me, a Oka strain is in which condition? Yes, Oka strain is used in varicella or chickenpox. Yes. Where is Gerald Lynn strain used? Where is Gerald Lynn strain used? Where is the Gerald? So Gerald Lynn strain is used in mumps. However, mumps. Danish 1331 is BCG, no yeah? BCG. Do not confuse. This is very, very important. You all should know. Right? Danish strain 1331 is used for BCG. Right? Then RA 27.3. Okay, I remember is that 27 divided by 3 is 9 and rubella is used in the ninth month. Okay, so it's the rubella. For rubella, it is RA 27.3. Okay, so Oka strain is for varicella and chickenpox. Edmundston Zagreb is for measles. Gerald Lynn strain is mumps. Danish 1331 is for BCG, and the RA 27 by 3 is the rubella. Okay, so this is the two very important strains you have to keep in mind. Next, coming to some of the immunodeficiency disorders, defects in the neutrophil NADPH oxidase system produce chronic granulomatous disease, Shiryak-Higashi disease, leukocyte adhesion deficiency, or Hashimoto's. Tell me, defects in neutrophil NADPH oxidase system will produce what? Chronic granulomatous disease, Shiryak-Higashi disease, leukocyte adhesion deficiency, or Hashimoto's. Very good. So the answer is chronic granulomatous. If there is an abnormality in the NADPH oxidase system, it will lead to the form of chronic granulomatous. What is Shiryak-Higashi disease? So basically, Shiryak-Higashi disease, what happens is there is a defect in the degranulation of the neutrophil. So there is defect in degranulations of neutrophils. Okay. So leukocyte adhesion deficiency, a very important thing you should know is there is a history of delayed delayed fall of umbilicus. Okay. So this history of delayed fall of umbilicus is a very important diagnosis of. Over here, these children will have high leukocyte count, very high. Okay. So when you see their counts will be above 50,000 and okay, so leukocyte adhesion defect, you have to know you should always ask for history of delayed fall of umbilicus. There might be a clinical scenario where they might give a 9-month-old child comes with recurrent fever, okay, very high grade fever, and there was a history of fall of umbilicus. What could this be? And this child was suggested for a stem cell transplant. What could this be? Okay, so in that case, the best answer is the leukocyte adhesion deficiency. Fine. Next question. Which of the following is true regarding Wiskott-Aldrich syndrome? Okay, so which is true? You have to tell me what is true out of the following. Platelet is large. It is a combined immunodeficiency due to abnormal cell motility. It is always a severe disease. It is common in girls. It is due to the mutation in the WASP gene in chromosome 6. So tell me what is true out of these five options. So this is a very, very important topic. Been asked in various exams. Okay, somehow everyone loves Wiskott-Aldrich syndrome. Tell me. Yes, well, very good, Sumitra. So the answer is it is a combined immunodeficiency, abnormal cell motility. So now coming to the other options, you have to know that the platelets in Wiskott-Aldrich syndrome is small. They have small platelets. So I've always told in my previous class, Wiskott-Aldrich syndrome has a spectrum. So the spectrum, it could be a mild disease to a severe disease. So these children present with eczema and they present with the bleeding. So in Wiskott-Aldrich syndrome, when they can present with just a mild symptoms like eczema, or in a severe condition, they can present with bleeding. And most of the time, these children die because of bleeding. Okay, so remember that. Next, coming to the 1 second. Yeah. So next coming to, it is common in girls. So it is not. It is a X-linked recessive. It is a X-linked recessive disorder. Okay, and that is why boys are more commonly affected. Okay, boys are more commonly affected. Next, coming to the mutation. So it is the WASP gene, that is the Wiskott-Aldrich syndrome protein is affected. The chromosome is chromosome 11. Remember, it is chromosome 11. Okay, it's not 6 chromosomes. So remember, in Wiskott-Aldrich syndrome, the platelets are small. Okay, it is a combined immunodeficiency. There is an abnormal cell motility, and there is the Wiskott-Aldrich syndrome spectrum. So the disease presentation varies from mild disease to severe disease. So they can have only eczema, but in severe disease they can have severe bleeding. Okay, and this severe bleeding can lead to death in these. So there is thrombocytopenia. It has an X-linked recessive inheritance. Therefore, the boys are commonly affected, and the mutation is the WASP gene, that is in chromosome 11. Okay, so this you have to keep in mind. And another very important thing, when it comes to the immunoglobulins, immunoglobulin M is decreased in these patients. Fine. Next, XLE-like syndromes is associated with the deficiency of SLE-like syndromes are associated with the deficiency of, is it myeloperoxidase, classical pathway, classical complement complements, classical pathway complement components, C1 inhibitors, or C8. SLE is common with the deficiency of which kind of complements? SLE. Yes, very good. So the answer is a classical path. So especially the C3 and C4, if this is deficient, it leads to SLE. Okay, so now coming, so that you have to know that a complement pathway has the early complement components like the C1, C2, C3, C4, while C5, C6, C7, C8 are the later components. So if there is a deficiency of C1, C2, C3, C4, these children have a chance of going for recurrent bacterial and fungal infections. Okay, while C5, C6, C7, C8, these children can go into having severe or recurrent Neisseria infection. Okay, so what happens if there is a C1 esterase inhibitor is absent? So what happens? That will lead to um, hereditary angioneurotic edema. Children will come with severe edema, something like anaphylaxis, hereditary angioneurotic edema. Okay, so remember, this is very important when it comes to complement system. So what deficiency of which complement leads to what kind of infections, and what deficiency leads to like symptoms. So this is very important. Okay, so now we come to the respiratory system. So there are a few questions in the respiratory system. So we'll be discussing that now. Okay, so clubbing can be seen can be caused by all except bronchiectasis, infective endocarditis, pneumonia, or ulcerative colitis. Tell me, clubbing can be caused by all except bronchiectasis, infective endocarditis, pneumonia, or ulcerative colitis. Yes, very good. Sumitra, the answer is pneumonia. So since the clubbing is always seen in conditions which are of chronic disorders, okay, chronic disorders can cause clubbing. So exactly over here in pneumonia, there is no, it is a very temporary condition, and that's why clubbing is very rare there. Okay, so tell me other lung conditions. So one is bronchiectasis, which causes clubbing. So tell me other lung conditions, pulmonary conditions, causes clubbing. Tell me other conditions, pulmonary conditions which causes clubbing. So one is bronchiectasis, which is already here. Tell me other conditions which causes. So tell me what are the other conditions which can cause pulmonary condition which can cause. So one is, it will be good if you all answer than me telling. If you do a mistake, you will be able to remember better. Okay, so one is lung abscess. Okay, empyema. Okay, if there is a chronic empyema, yes, cystic fibrosis. Okay, chronic empyema, and pulmonary tuberculosis. Okay, so these are the few causes, pulmonary causes, which can cause clubbing. So now tell me what are the cardiac causes. So one is infective endocarditis, another is other is one is infective endocarditis. Another cause for clubbing is in cardiac causes, especially in children, is one is infective endocarditis. What is the other cause? Very important cause in children, especially they'll have clubbing. So they present with cyanosis. So you should be able to tell me. This is a condition, cardiac condition, they'll present with cyanosis. Okay. I'll tell you cyanotic congenital heart disease. Okay, so cyanotic congenital heart disease, another condition, heart disease, they will present with clubbing. Okay, ulcerative colitis and Crohn's disease both present with clubbing. Okay, so that is one. Okay, tell me what is a hepatic cause which can very good, Sumitra, you've told cyanotic. Hepatic cause being cirrhosis, while endocrine cause causing is mixed edema. Okay, so these are the few causes of clubbing you have to keep. So that's pulmonary, cardiac, intestinal, hepatic, and endocrine. Okay, so these are the various causes of clubbing you have to keep. Next, mediastinal shift to the opposite side is seen in all conditions except. So mediastinal shift to the opposite side is seen in all of the conditions except pleural effusion, pneumothorax, hydropneumothorax, or fibrosis of the in the lung. Where do you? Very good. The answer is very simple. So fibrosis in lung. So what happens in fibrosis of the lung? The mediastinum or the it is pushed towards the same side, pulled towards the same. Okay, while there is no pushing happening. Fine. Mediastinal shift of the opposite side is not seen in fibrosis in the lung. Okay. Cause of wheezing are all except bronchial asthma, hypersensitivity pneumonitis, Loeffler syndrome, or laryngotracheal bronchitis. Tell me what are the causes of wheezing are all except bronchial asthma, hypersensitivity pneumonia, Loeffler syndrome, or laryngotracheal bronchitis. Yes, very good. So the answer is laryngotracheal bronchitis. All of the three others present with wheezing. Fine. Next, pigeon-shaped chest is a feature of rickets, mucopolysaccharidosis type 4, massive cardiomegaly, or all of the above. Pigeon-shaped chest. Pigeon-shaped chest is the feature of rickets. So they have asked a lot of questions based on shift of the mediastinum, based on this chest deformities. In a lot of questions. So tell me, pigeon-shaped chest is a feature of rickets, mucopolysaccharidosis, massive cardiomegaly, and all of yes, very good. So it is seen in all of the above conditions. Okay, so now tell me other condition. What is pectus pigeon chest? So pigeon chest is pectus carinatum. So basically it is a bulge. Okay, while pectus excavatum, where the chest there is a hollowing of the chest. So the chest goes backward. I mean there's a hollow. So this is pectus excavatum. So you have excavating. Okay, excavatum. While the bulge is called as the pectus carinatum. Okay, so yes. So tell me some other conditions where there could be pigeon chest, pigeon shaped chest. So in emphysema there could be, okay, in Marfan syndrome, Noonan syndrome. Okay, so these are some genetic conditions you have to keep in mind where there is a pigeon shaped chest. Okay, where there is pectus carinatum. Okay, so this you have to keep in mind. Next, mediastinal position is in center in all except mediastinal position is in center in all except pneumonia, bronchiectasis, emphysema, or fibrosis. Mediastinal position center in all except mediastinal position is in the center. Okay, is it pneumonia, bronchiectasis, emphysema, or fibrosis in which the mediastinum is not in the center? Yes, very good. So the answer is fibrosis. So what happens in fibrosis? Mediastinum is towards the side of fibrosis. While pneumonia, bronchiectasis, and emphysema, they do not cause any kind of change in the mediastinum. So remember, fibrosis fills the mediastinum wherever. So if there is a fibrosis, so if there is a lung and there is a fibrosis happening here in, okay, so this trachea gets pulled towards the side where this fiber. So along with that, the mediastinum also gets pulled. Okay, so there is pull towards it. So that is why it is fibrosis. Okay, so when there is fibrosis, there is the mediastinum gets pulled towards it. Okay, so the answer is fibrosis. Steeple sign on chest X-ray is a suggestive of acute epiglottitis, laryngotracheal bronchitis, Loeffler syndrome, hypersensitivity syndrome, pneumonitis. Tell me steeple sign on a chest X-ray is suggestive of. Steeple sign is very important, so remember and tell me. It is suggestive of which condition? Steeple sign. So tell me steeple sign is a condition. Yes, Very good. So the answer is laryngotracheobronchitis. Fine. Next condition. Not used in the treatment of croup. Antibiotics, adrenaline, oxygen, or dexamethasone. What is not used in the treatment of croup? Antibiotics, adrenaline, oxygen, dexamethasone. So tell me, what is not used in the treatment of croup? Take your time. Around say. What is not used in the treatment of croup? Very good. Antibiotics are not used in the treatment of croup. Very good. Next question. Childhood cough which worsens at night strongly indicates what? So in a child, the cough is more in the night. Yes. Yes, Sumitra. Laryngotracheal bronchitis, epiglottitis, pneumonia, asthma. Childhood cough worsens at night. It's strongly indicative of what? Laryngotracheal bronchitis, epiglottitis, pneumonia, or asthma. Very good. Asthma. So yes. So what happens in children with asthma is there is the history that they suddenly wake up because of the severe bronchoconstriction. Okay, so that becomes, and they do not get good sleep, and because of this that affects their daily activities. They might not be going to school. So whenever you have a child who comes with symptoms of asthma, you tell them to make a diary of how many episodes do they have in a week. So based on that, we can tell this child is severe a case of asthma or a mild case of asthma. Okay, so childhood. So whenever there's a very important history you have to ask. So one is, does the child wake up from the sleep because of cough or the sleep is disturbed? Second, is the child school school activities affecting when I mean us telling the child is on a lot of leaves, not going to school. Thirdly, are the symptoms improving after taking the inhaler? Okay, so that these are all the points which suggest asthma. Okay, next, the most common etiological agent for acute bronchiolitis. Okay, I'm talking about bronchiolitis in infancy is the most common etiological agent for acute bronchiolitis in infancy is it influenza virus? So laryngotracheal bronchitis, it worsens but not necessary in the night. Okay, not necessary in the night. Asthma is a typical picture where it worsens in the night. Okay, so Rehan, so in laryngotracheal bronchitis, it is not necessary that the symptoms worsen in the night. Asthma, it's a typical picture. There is a bronchoconstriction happening. Okay, that happens with the more in the night because of the decrease in the temperature. Okay, there is warmer temperature, a cooler temperature in the night. So that is the reason. So it is more common in asthma and not in laryngotracheal bronchitis. So whenever there is a recurrent history of cough worsening in the night is a typical presentation of asthma. Okay, fine. Now, yes, Sumitra, you're right. So the answer for the most common etiological agent for acute bronchiolitis is RSV, that is respiratory syncytial virus. Respiratory syncytial virus. Fine. Next question. Pulmonary function test in bronchiolitis obliterans shows. Pulmonary function test in bronchiolitis obliterans shows. Is it obstructive pattern, restrictive pattern, both obstructive and restrictive pattern, or is it a normal pattern? So tell me, what is the pulmonary function test in bronchiolitis obliterans? Yes, very good. It is a obstructive pattern. Okay. So over here what happens, there is a complete or partial obstruction of the airway lumen and that will cause air trapping and atelectasis. Okay. So there is a complete or a partial obstruction of the airway. So this is SP, this bronchiolitis obliterans is especially seen in children who undergo lung transplant or hematopoietic stem cell transplant. It's more common. It's more common to develop in children who require lung transplant or hematopoietic stem cell transplant. Okay, so the answer is obstructive pattern. Okay, so now tell me, tubular breathing is heard in, is it cavity, consolidation, pneumothorax, or pleural effusion? So tell me, tubular breathing is seen where? Tubular breathing is seen in cavity, consolidation, pneumothorax, or pleural effusion. Think and answer, and after that you have to tell me in other conditions what do you see. Tubular breathing, I'm talking about tubular breathing. So in tubular breathing, you is seen in consolidation, that is pneumonia. So in tubular breathing is seen in consolidation. Also, what are the other causes, other conditions where you hear tubular breathing? Tell me other conditions where you hear tubular breathing. Other conditions where there is tubular breathing, you'll tell me, no? So other conditions along with pneumonia or consolidation, one is collapse. Okay, if there is an infarct of the lung, the infarct of the lung, you hear tubular. Okay, so you hear tubular breathing. What do you hear in the cavity? What kind of a breathing do you hear in cavity? Yes, fibrosis as well. So now tell me, in the cavity, if there is a cavity in the lung, what kind of a breathing do you hear? If there is a cavity, what kind of a breathing you hear? This goes by the name itself. Okay, so in a cavity you hear a cavernous type of breathing. Cavernous, more of a hollow kind of cavernous breathing. Okay, now if there is a pneumonia, it is communicating with the bronchus. If there is a pneumonia which is communicating with a bronchus, then what do you hear? Then what do you hear? Then you hear amorphous breathing. Okay, so remember, so tubular breathing is a feature of consolidation or pneumonia, collapse, infarct of a lung, and cavernous breathing is a feature of cavities, while amorphous breathing is a feature of a pneumonia, which is communicating with the bronchus. Okay, fine. Next question. So tell me, giant cell pneumonia or H pneumonia is a feature of which infection? Is it CMV? Is it measles, malaria, or Pneumocystis carinii? So tell me, giant cell pneumonia is a feature of which condition? CMV, measles, malaria, or pneumonia? Very good. So the answer is measles. This is a very important question, and a lot of questions have come. So giant cell pneumonia is a picture of measles. Very good, Rehan and Sumitra. Next question. Pneumatoceles is caused by. Pneumatoceles is caused by. Pneumatoceles is a feature of which infection? Staphylococcus, Streptococcus pneumonia, all of. So tell me the best answer out of all. Okay. Pneumatocele is a feature of which infection? Staphylococcus, Streptococcus pneumonia, or is it Pneumocystis carinii? Very good, Sumitra. The answer is Staphylococcus. This you have to know. Very, very, very important. Generally, the most common cause of pneumonia is Streptococcus. Staphylococcus do not cause that much of infection. But if a child develops pneumonia because of Staphylococcus, then pneumatoceles happen. So basically, what is pneumatoceles? There are air-filled pouches in the lung. Very bad. Okay. I will tell you the next question. You will come to know why it is bad. So pneumatoceles is a feature mixture of Staphylococcus, and the best next best thing is the Klebsiella. Next, tell me, pneumothorax could be a complication of staphylococcal pneumonia, streptococcal pneumonia, Klebsiella pneumonia, or viral pneumonia. Tell me, pneumothorax could be complication of which? Staphylococcal pneumonia, streptococcal pneumonia, Klebsiella pneumonia, or viral pneumonia. Very good. So staphylococcal pneumonia. So that is the reason we're scared if a child develops pneumonia due to staphylococcus. So staphylococcus invariably they will have a pneumatocele. They will cause pneumatocele, and there is a spontaneous rupture of a pneumatocele which can present as pneumothorax, and this child will eventually need a ICD drainage of the pneumothorax. So that is why staphylococcal pneumonia has a serious complication of developing into cataracts. Okay, so that is why whenever you get an X-ray for a child with pneumonia and you see a gaseous blebs, brown blebs of gaseous shadows, then that should give you a clue. This could be a staphylococcal pneumonia. Fine. Next question. The drug of choice for Mycoplasma pneumonia is tetracycline, staphylococcus, cotrimoxazole, erythromycin. The drug of choice for Mycoplasma pneumonia is tetracycline, staphylococcus, cotrimoxazole, or erythromycin. For Mycoplasma pneumonia. Yes, and think and tell me, what is the drug of choice for Mycoplasma pneumonia? I think you all are confusing yourself here. So the answer is erythromycin. So if there was an azithromycin option, you would have gone for azithromycin. So erythromycin is used, okay? Erythromycin or azithromycin, same groups, okay? So that is the drug of choice for Mycoplasma pneumonia. Okay, so this is a very common cause for the community acquired pneumonia, right? So this is one of the very common cause for community acquired. Yeah, fine. Next, chocolate colored sputum is seen in chocolate colored sputum is seen in Mycoplasma, Legionella, Pseudomonas, or Klebsiella. Chocolate colored sputum is seen in which condition? Is it Mycoplasma? See, you should make certain notes like this. Where do you see chocolate colored sputum? Where do you see, okay, a normal, this thing, greenish colored sputum? So that and all should be made a notes of. So now tell me, chocolate colored sputum is seen in which condition? Yes, Sumitra, your your uh, your doubts is right. So the answer is Klebsiella. Klebsiella causes a chocolate colored sputum. Fine. Next question. Atypical pneumonia can be caused by all except Mycoplasma pneumonia, Legionella pneumophila, human coronavirus, or Klebsiella pneumonia. Tell me, atypical pneumonia can be caused by all except Mycoplasma pneumoniae, Legionella pneumophila, coronavirus, or Klebsiella pneumonia, atypical pneumonia. So these are very rare causes of developing pneumonia. Okay, so they will not have the specific definitions of pneumonia. What we say? Tell me. Yes, very good. So the answer is Klebsiella pneumoniae. Okay, so atypical pneumonia is seen in Mycoplasma pneumoniae, Legionella pneumophila, human coronavirus. Okay, but in Klebsiella pneumoniae is a typical causative agent to develop pneumonia. Fine. Hemolytic anemia is seen in which pneumonia? Hemolytic anemia is seen in which pneumonia? Is it chlamydia pneumonia, pneumocystis pneumonia, mycoplasma pneumonitis, or aspiration pneumonitis? Tell me, out of the following conditions, where do you see hemolytic anemia? We have discussed, I think, in a previous class as well. You will be able to tell this. Hemolytic anemia is seen in which condition, which type of pneumonia? Which is the bacterial or which is the causative organism? cause, the hemolytic picture, anemia kind of a picture. Very good. So the answer is Mycoplasma pneumonitis. So you all know, right? The cold antibody, yes, IgM. So the cold antibody mediated hemolytic anemia happens in in infection because of Mycoplasma pneumonia. That is the complication of a Mycoplasma pneumonia. Okay. So when the body becomes cold, there is a hemolytic anemia kind of a picture in a child, in a patient who has Mycoplasma pneumonia infection. So hemolytic pneumonia is seen in Mycoplasma pneumonia. Very good, both of you. True about Legionella pneumonia, interstitial pneumonia, dry cough, diarrhea, or all of the above. So tell me, Legionella pneumonia, how will they present? Is there interstitial pneumonia, dry cough, diarrhea, or all of the above? Yes, very good. So Legionella, all the three are present. It's an interstitial pneumonia. There is a dry cough. There is no expectoration, and they will always present with diarrhea. Okay, so that is one of the features. Okay, which of these is the most likely cause of walking pneumonia? Okay, so I will tell you what is walking pneumonia, but you tell me what is the cause. So what is the most likely cause of walking pneumonia? Staph aureus, Klebsiella pneumonia, Streptococcus pneumonia, or Mycoplasma pneumonia? What is the most likely cause of walking pneumonia? What is the most likely cause of walking pneumonia? Yes, very good, Sumitra. So it's Mycoplasma pneumonia. So what happens is when you have hmm, a pneumonia with Mycoplasma pneumonia, when it's an infection with Mycoplasma pneumonia, you get a chest X-ray. When you get a chest X-ray, you see there is a very horrific patch, but the patient is fine. The patient is walking and active and everything, but there is a huge patch which you see. That is why, even though you have a pneumonia, the patient is able to walk and do his regular activity. Why it is called as walking pneumonia. And the cause, most important cause, is the Mycoplasma. Fine. All of the following is used in the management of an acute attack of asthma in a 4-year-old child, except, okay, all of the following is used in the management of an acute of asthma in a 4-year-old, except theophylline, corticosteroids, sedatives, or salbutamol. Okay, so this is a management of an acute attack of asthma in a 4-year-old child. What would you not use out of the following options? Yes, very good. So you will not be giving sedatives. The child will require theophylline because it is a respiratory stimulant. Corticosteroids are given to reduce the inflammation, while salbutamol is given so that there is the bronchodilation happening. While sedatives are not given, so it will only suppress the child. So right, the answer is sedatives. Fine. False regarding bronchiectasis. So is it clubbing, hemoptysis, recurrent infection, or restrictive pattern on spirometry? False regarding bronchiectasis. What out of the following options is false? Clubbing, hemoptysis, recurrent infection, restrictive pattern on spirometry. Clubbing, hemoptysis, recurrent infection, restrictive pattern on spirometry. Think and answer. You have your time. Think and answer. Very good. So the answer is restrictive pattern. So what is the pattern on spirometry for bronchiectasis? It is the obstructive pattern. The obstructive pattern for bronchiectasis. Okay, very good. Next. Which of the following is not a complication of bronchiectasis? Is it lung abscess, lung cancer, amyloidosis, or is it empyema? So which is not a complication of bronchiectasis? Which of the following is not a complication of bronchiectasis? Is it lung abscess, lung cancer, amyloidosis, or empyema? Okay, very good. That is lung cancer. So tell me what are the others? So one is lung abscess, amyloidosis, empyema. What are the other complications? What are the other complications? So one is pneumonia. There could be pneumonia, right? There could be pleural effusion. There could be pleural effusion. What else? There could be a pneumothorax. What other causes? What other complications can happen? There could be pneumothorax. There could be pneumonia. There could be pleural effusion. What else can be there? There could be hemoptysis, and eventually there can be cerebral abscess. Remember, there could be cerebral abscess. So remember, these are the various complications of a child with bronchiectasis. Lung abscess, amyloidosis, empyema, pneumonia, pleural effusion, pneumothorax, hemoptysis, cerebral abscess. Okay, so these are all the complications of bronchiectasis. So next coming, bronchiectasis is the most common lobe to be involved in the lung. Which is the most common lobe to be involved? The right upper lobe, right middle lobe, or left upper lobe, or left lower lobe. So tell me, which is the most common lobe to be involved in bronchiectasis? Tell me what is the most common. Yes, very good, Rehan. The answer is 4. That is the left lower lobe. So the left lower lobe is the most common. Okay, so just have a picturesque image in your mind. So if this is right and left, okay, left lower lobe. Okay, so the left lower lobe is the most involved lobe of bronchiectasis. Fine. What is the investigation of choice for bronchiectasis? Is it chest X-ray, HRCT of the chest, Sputum culture, or spirometry? Tell me what is the investigation of choice for bronchiectasis? Chest X-ray, HRCT of the chest, or is it sputum culture, or is it spirometry? Yes, yeah, very good. So the answer is HRCT of the chest. That is the most common, most important investigation of choice for bronchiectasis. Next. Now coming to cystic fibrosis, infants with cystic fibrosis are likely to develop. Infants with cystic fibrosis are likely to develop meconium ileus, loose motion, vomiting, or constipation. So tell me what more infants, we're talking about infants, infants with cystic fibrosis are more likely to develop. Yes, the answer is meconium ileus. They can have constipation as well, but then there will be this alteration of constipation and diarrhea. But meconium ileus, you have to remember, and we are talking about infants over here. So infants with cystic fibrosis, think about meconium ileus as the answer. Okay, so these children can develop into having meconium ileus. Now tell me which of the following statement is not true about cystic fibrosis? Of the following statement is not true. So is it autosomal recessive inheritance? Is it abnormality in the CTFR gene which leads to defective calcium transport, or mutation in the transport regulator, or all of them? What is not about cystic fibrosis in the following options? What is not true? Autosomal recessive inheritance, abnormality in the CTFR gene which leads to defective calcium mutation and CF. Yes, very good. The answer is, tell me what is the answer? The answer is 2. Oh, there is the defective chloride. So defective chloride transport. Defective chloride transport. Very good. Okay. Okay. So we have come to the end of the, yes, we've come to the end of the questions. So I thought I will do a little bit discussion on bronchiectasis and cystic fibrosis, a small discussion. Okay. So now I will ask you a few questions. You'll tell me. Okay. So now tell me few of the causes of bronchiectasis. Tell me the congenital causes of bronchiectasis. So I'll talk only for like 15-20 minutes and end the class. Okay. Bronchiectasis. So tell me some of the causes. So in the causes, now tell me what are the congenital causes? Congenital causes of bronchiectasis. What are the congenital causes of bronchiectasis? Give me two of. There are two things which I want you to tell me. Tell me one at least. What are the congenital causes of bronchiectasis? Okay, so there is something called as the Young's syndrome. Remember, do you all know that? Young's syndrome. Right? So over here what happens? There is male infertility and there is bronchiectasis. There is male infertility and bronchiectasis. Tell me another congenital condition which can cause bronchiectasis. Yes, that is all the complication of cystic fibrosis. They will not present with bronchiectasis. Okay. So now tell me, one is Young syndrome and the other is the primary ciliary dyskinesia or the Cartagena syndrome. Okay. Primary ciliary dyskinesia or the Cartagena syndrome. Yes, very good, Vasavi. So tell me what is the triad of Cartagena? Tell me the triad of Cartagena syndrome. Yes, very good. Situs inversus, bronchiectasis and and a very important feature is sinusitis. Sinusitis. Okay, so this is the triad of Cartagena. There are two conditions with bronchiectasis that you should remember is Young syndrome, where there is male infertility and bronchiectasis a presenting feature. Another is the primary ciliary dyskinesia or the situs inversus, bronchiectasis. And so this Cartagena syndrome will also have infertility. But the triad includes bronchiectasis, sinusitis inversus, and sinusitis. Fine. So that is one thing. Next, what are the other causes, like the post-infectious causes? What are the post-infection? What are the infections which can cause bronchiectasis? So it could be the measles infections. Okay, the measles infection. It could be there could be pertussis. Okay, tuberculosis, pneumonia. Pneumonia can become bad and lead to bronchiectasis. So that is one. Okay, so the main organisms causing bronchiectasis, which is very important, you should know. The main organisms causing bronchiectasis is H. influenza, Streptococcus pneumoniae, Staph aureus, and Pseudomonas aeruginosa. So this Pseudomonas aeruginosa is the positive agent to cause bronchiectasis in cystic fibrosis. Pseudomonas aeruginosa. So you should know about these positive organisms which can cause bronchiectasis. So H. influenza, Streptococcus pneumonia, Staph aureus, and Pseudomonas aeruginosa. These are the various important organisms causing bronchiectasis. Next, so if there is a foreign body or if there is a tumor, so if there is a bronchial obstruction happening, if there is a foreign body or a tumor, that can lead to bronchiectasis. Bronchial obstruction. Okay, bronchial obstruction. Bronchial obstruction can cause. 1 second. Yeah. So bronchial obstruction can cause. Next, fourthly, there will be you should know that aspergillosis. Okay, there is pulmonary aspergillosis, allergic pulmonary aspergillosis. Okay, ulcerative colitis can cause. Okay, basically as a component. Okay, rheumatoid arthritis, cystic fibrosis. These are the various conditions that can cause bronchiectasis. The main condition is the Young syndrome and the Carter-Green. And another very important is the organism that cause bronchiectasis: H. influenza, Streptococcus pneumonia, Staph aureus, as well. So these you have to keep in mind. Okay, so now you know all the complications of bronchiectasis we have already discussed. Okay, so tell me, when you get a chest X-ray, bronchiectasis, what is the sign called? Chest X-ray for a bronchiectasis, what is the sign called? What is it called? So it is called as the tram track appearance with ring shadows. Okay, so basically there is this cystic shadows which you see around the thick bronchial walls. That gives a tram track appearance with ring shadows. So there is another condition where you see tram track appearance. Tram track is seen in a honeycomb. Yes, very good. Honeycombing is also seen. Tram track appearance with ring shadows. Honeycombing, combing is also seen. Very good. Tram track is another condition also. You all know each other condition. It is a CNS condition. Where is it seen? Tram track, yes, very good, Sumita. So tram track is also seen in when you get a CT or MRI in Sturge-Weber syndrome. Sturge-Weber syndrome. So they have this port wine stain in Sturge-Weber syndrome. Okay, so this is it. And you know the HRCT, the investigation of choice. HRCT is the investigation of choice. And when you get a spirometry, you have a obstructive pattern. Okay, so this you have to know. Very good. So now coming, next topic we'll discuss is cystic fibrosis. So you know what is the inheritance of cystic fibrosis? So what is the inheritance of cystic fibrosis? The cystic fibrosis is autosomal recessive, right? And the gene involved is the CFTR gene. So now tell me which chromosome is involved? The CFTR gene, which chromosome which is involved? So tell me the chromosome for cystic fibrosis which is involved. Yeah, one is it is autosomal recessive, yes, but it is the CFTR gene. Chromosome which is involved is the chromosome 7. Very good, Sumita. It is the chromosome 7 which is. What happens in CFTR genes? There is a defective chloride secretion and there is an increase in sodium absorption. So this will lead to defective chloride secretion and an increased sodium absorption. Okay, so this is what. So this happens in the airway epithelium. Happens in the airway epithelium. Okay, so what happens? What happens? It becomes so chronic pulmonary infections, bronchiectasis, chronic pulmonary and bronchiectasis. Very important. So the complex of cystic fibrosis. Children will not be born with it. So basically, there is a recurrent pulmonary infection pseudomonal infection happening here, and that will lead to bronchiectasis. Okay. So in children with cystic fibrosis, neonates, how will they have? What will they present with? So one you have already said. So how will they present with? Yes, delta 508. Very good, Sumitra. So now tell me in neonates, how will they present? So in children, neonates, they will have failure to thrive. Then they'll have failure to thrive. They will have, 1 second. Um, so in children, neonates have, yeah. So there is failure to thrive. Then there is meconium ileus. Yes, very good. Meconium ileus. Then they can also have rectal prolapse. Okay, so they can also have rectal prolapse. Steatorrhea. Yes, that steatorrhea happens. Why? Because of the pancreatic insufficiency. So in children, so as the child grows, so there is in the what are the respiratory symptoms? So in neonates, you know there is meconium ileus, there is failure to thrive, there is rectal prolapse. But as the child grows, or in young adults, what are the respiratory symptoms? How do they present? So they'll have recurrent infections. Yes, recurrent infections. They can have bronchiectasis. They can have pneumothorax. They can have hemoptysis. So all the respiratory presentations will be there. Now coming to the gastrointestinal presentation. So how will they present? They have steatorrhea, very good symptom. They have pancreatic insufficiency. So based on this pancreatic insufficiency can lead to diabetes and steatorrhea in these. Okay, diabetes and steatorrhea. Okay, then they can also have distal intestinal obstruction. So in children, you see meconium ileus. In neonates, you see meconium ileus. In an older child, you see distal intestinal obstruction syndrome. So it's similar to meconium ileus. Distal intestinal obstruction syndrome. Okay, they can have gallstones. They can have cirrhosis. Okay, so these are the various presentations. Next, in the males, there could be male infertility. Okay, hypertrophic pulmonary osteoarthropathy. So remember, this is very important. HPOA, hypertrophic pulmonary osteoarthropathy. Osteoarthropathy. Okay, and signs be there is clubbing, there is cyanosis, and when you auscultate because of the repeated infections, there is bilateral chords, crackles, or crepitations. Bilateral chords, crepitations, what you will see. Okay, so this is very important. So as a neonate, you will see meconium ileus, there could be rectal prolapse, or these children can have failure to thrive. But as a child grows, in a child or in a young adult, you see recurrent infections, bronchiectasis, pneumothorax, hemoptysis can happen. The gastrointestinal presentation be pancreatic insufficiency, presence of diabetes, steatorrhea. So and there is distal intestinal obstruction syndrome, which is a similar to the meconium ileus, which happens in a neonate. They can have gallstones, cirrhosis, male infertility, hypertrophic pulmonary osteoarthropathy. Very important in case of your point of view. So how do you manage these children? How do you manage? So very important is because there is clogging of the bronchus because of the severe secretions. Will need physiotherapy. Okay, so they need physiotherapy regularly. Okay, they need antibiotics. Okay, so these children have severe exacerbation of infections and will require antibiotics. Mucolitis, because there is very thick secretions in these patients and they'll require mucolitis and bronchodilators. Okay. Next, since they have pancreatic insufficiency, you have to do certain pancreatic enzyme replacement should be done, and fat soluble vitamin should be supplemented. That is the ADENK, fat soluble vitamins should be replaced. Okay, so this, and also you all know there is the impaired liver function. Yes, yes, very good. Okay, so ursodeoxycholic acid should be given, and if there is cirrhosis, these children might go for liver transplanting. Okay, so this much you should know about cystic fibrosis. So we have discussed what are the presentation, what is the presentation in a child or in a young adult, what is the management they have done. This is the very important thing you have to. Okay, so now before I end, I will talk about what are the common organisms you see. Okay, what are the common, one second, what are the various common organisms. Yeah, so in common cold, so in common cold, yeah, so in common cold, the most common organisms. So tell me, what is the most common organism for common cold? What is the most common organism? Which is the virus which causes common cold? The most common is rhinovirus. Okay, this you have to know. Okay, rhinovirus. No, I'm talking about the virus. The most common for common cold is rhinovirus. This has come in a question and I didn't discuss. That is why I am discussing here. What else? Yeah, so we are done for today. I have discussed most topics. Mm, yeah, yeah. So we have discussed most of the topics today. This is it for today. Okay. Mm, so today will be my last class here in the YouTube. Okay. Another one class I have pending in this thing in the Unacademy special class. Tomorrow for 2 hours I will have a Unacademy platform. So around, I think this will keep, so tomorrow is Wednesday, right? Yeah, so somewhere between 5. So I'll have a class at 3 to 5 in the Unacademy special class. So again, this is going to be a quiz. So whatever topics I have not covered in the last few days, yes, tomorrow that will be a special class. And YouTube classes are done. So I'll not be doing any more YouTube classes. So today is the last class here. Um, the quiz in special class I will be doing at 3 to 5 tomorrow. So all these renal, we have not discussed renal, so we'll do renal and CNS. So all the questions which have come in the past for renal and CNS I'll be discussing tomorrow in the special class for Unacademy. Okay, so that will be a 2-hour class. So whatever, how much ever questions I will discuss on tomorrow. Okay, so that will be the last class. Fine. So all right. So we've come to the end of this class. So very important. My question part 10, get a 10% discount on the subscription. And another very important thing is, the 4 things what I always say is, study daily. Do not have a break in your study. So that if you have a single break in your, what will happen is you go into the lazy mode, and then again, get frustrated and you not have a continuity. So at least if you're having a break, study at least for 1 hour that day, so that continuity is maintained. That is very important. Second, avoid social media. You will waste time. So now if you attended my class, done. Pick up the phone and do. Or if you're attending someone else's class, okay, do that. But don't go into any social media like your Instagram, Facebook, Snapchat. All that will only waste your time, and you will not be able to concentrate on studies. Okay. Thirdly, I always tell sleep early and wake up early helps to helps your memory. Okay, it helps you to remember better. But okay, I'm not saying early meaning 9 o'clock. Sleep at 11 o'clock and wake up at 7. Okay, yeah, that's what I'm talking about. That so wake up at 7. So I'm telling you what all is important. So this is all a part of preparation. So wake up at least at 6 or 7, and then start studying. Do not wake up late and sleep 2 o'clock, 1 o'clock studying. That will not help you. At least study sit at 11 o'clock. Okay. Then, if you have any study partner, discuss with them. So what happens is, it will not for like full day discussion. You go half an hour or 1 hour in a day to discuss. So then when you all discuss, you all will remember better. You tell, he tells, she tells. So you all will able to discuss. Only discuss about studies. Don't discuss about any some XYZ topic, and then you all will derail from the main topic. So discuss about it so that you will be able to remember better. Another very important thing is the grand test. Okay, at least once in your 300 questions. Okay, set your time limit and do it, because that will help you to learn how to manage time. Because what happens is, in most of the time, very good students, they will not be able to 100 questions, and there the problem happens. So even if you finish the 300 questions one stretch, you will have to go back and see questions if you're able to know. Sometimes what happens, it will be a tough question. You will leave that question and go to the next question. But I finished the 300 question, and now you don't have time to go back to the that difficult question you had left. So you shouldn't be doing that. You should be able to finish your 300 questions, and you should have enough time to go back and see those questions again. So that is very important. So that is why grant test helps. Okay, so the grant test helps you. First thing, it will help you to you will come to know what topics I don't know. Second, it will help you in managing time. That is very important. Once in you have to attend grant test, it will help you very much. So all the subjects should be involved in the grant test, not just pediatrics or not just OBG or medicine. All the subjects should be involved. So that will help you in managing time. Okay, you might be thinking, no, I have not studied this subject. I'll not do grant test. Just randomly do grant test. It will only help. Okay, so these are the few things I tell, and be very disciplined. No, this is a 90 subject thing. There is so many things to remember, and make short notes. So whenever you make notes, right, make a short note, and everything should be there in one page. That should help you to revise better. So this main thing is all about revising. You know that, right? So you should be able to make very important points, so that by the time you revise, you'll be able to revise it faster. You shouldn't be reading the entire story again in your revision. So reading again the entire story doesn't work at all. Okay, so whenever you're reading for the first time, make short notes, so that when you go back, when by the end of during your what is at least 1 month before your NEET PG, you should be able to revise fast with those short notes. Where that is very important. Writing notes is not writing an entire textbook. Writing notes is short, short brief notes of every topic. Okay. Yeah, I don't have a Telegram link, Sumitra. Um, if I have, I'll let you all know. I haven't got a Telegram link yet. Okay. So, all right. So, this is very important. So, this is what I have told. If you all remember, you all will be able to crack your exam. Studying daily is the key. Studying daily is the key. What happens is that break, once you all start taking break, you all will that interest to study. So, study daily. Keep a friend with whom you all can discuss the topics. Help you all a lot. Okay. So, all right. See you then. Thank you, Sumitra, Dayal, Vasavi, and I think Dr. Rehan had come. Okay, so all right, good luck, stay safe, stay healthy, and study well. So, tomorrow in the special class in the Unacademy app, I'll be having a class between 3 to 5, and that will include questions on renal system and the central nervous system related to pediatrics. Okay, so see ya. Good night. Goodbye. Bye.